You know, WHO puts universal health coverage in the center of its work to make sure that no one is left behind. And this is based on the principles of primary health care. It looks at access, it looks at affordability of those services, but it's also looking at the quality of services at preventive level. It means that at your most primary care level, what you put there and what you do at that level. The Kingdom of Eswatini has been a signatory to the Alma Ata from a long time ago. So primary healthcare has been the approach we've been using to ensure that we can reach everybody. But to make sure that we are now looking at universal health coverage, we've been building up on facilities and services across the country, slowly building up clinics in rural areas and ensuring that those areas that are hardest to reach have services. But more importantly is been making sure that there are professionals in place there to make sure they're giving the services. And recently we've been looking a lot more in terms of the tools we give to these professionals. From the work we've been doing with HIV and TB, we put in a lot of tools at primary healthcare level to make sure that people can have access to proper diagnostics and have immediate help at that level. And recently, we've been adding more of those tools, ensuring that people can now have NCDs checked. You know, we are doing a lot of work around diabetes, checking that we're rolling out. We have tools now in most of our clinics. Hypertension, which is very common, but we are also, because of the burden of HIV that we carry, we are also screening for cancers, particularly cervical cancer. So at a lot of the primary healthcare level, people can be screened, and at the next level, people can be screened and treated for cervical cancer. We're doing a lot of prevention work. So universal health care coverage for us means that people can access the services where they are in the nearest possible area, but also reducing the cost for the person to get to those services. People pay less than $1 to get to tertiary care level. It means that you're coming into hospital, you're going to get diagnostics, you're going to see a professional there, you might even be admitted, and you're going to get medicines. So that's how cheap it is. But in the rural areas, people pay very little. All people over 60 are not charged anything. And if all the children under 6, they're not charged anything. And around COVID, we raised that age to about 12, that all children under 12 should not pay anything coming into the health service. So health service to the consumer, to the Liswati, should cost very little. However, we still have some challenges, you know. Recently, looking at the resolution on diagnostics, on improving diagnostics, we've been taking stock of what we have there. And we know that we need to do more, to put more tools that are going to be more user-friendly, and also that those tools will be in the hands of the professionals that are there. The second challenge is ensuring that all our healthcare professionals at primary care level have the skills to actually use those tools and the skills to be able to know when to refer to tertiary level. So universal healthcare coverage is really very much in the core of the work we're trying to do. We want to leave no Liswati behind.